everyone. Now let me discuss the FMGE recall questions of August 2020. So I definitely can understand it was a nightmare for all the FMGE students who have written this particular exam. So I feel very pity and as well as sorry about this exam for all of you who have attended this exam. And this is the pattern of the exam that shouldn't have been given to the FMGE students who are appearing for the screening test. And whatever is the support which we can give from the faculty point of view, definitely we will help you in any point of time. So with this basic introduction, let me just go ahead and start with the recall questions. So first of all, I specially thank the students Raviteja, Prashana, Isha and as well as Omkar. So these are the students who have helped me a lot in recalling the questions. And let me tell you that these are completely a recall. Okay. So this particular recall, it might be incomplete also, right? I'll be showing you some of the questions where the options are not completely there for the individual questions. All the 4 options are not there. Why the students were unable to recall, right? Because the questions were very lengthy questions, and even the entire question frame up was also unable to be recalled because the entire question was almost like 4 to 5 sentences. And images which I'll be showing you for the individual questions may not correlate the images what has appeared in your exam. So with this basic introduction, now let me start the discussion of the questions now. So this was one of the question which has been asked in your exam. They gave a patient had a history of syncope and diagnosed as a case of the aortic stenosis. Which of the following will you find in the X-ray? PA and as well as lateral view were given, and these are the following options, that is post-stenotic dilatation of the aorta, dilatation of the aortic valve, widening of the aortic knob. These were the options and this was the chest X-ray given. Chest X-ray of the aortic stenosis. Now in case of aortic stenosis, let me tell you first of all, it is characterized by a triad. The clinical manifestations are characterized by a triad. Now what will be the clinical manifestations? Number 1, it includes syncopal attack, then angina, then dyspnea. So these are the clinical manifestations or the triad what you will have in aortic stenosis. And in patients with aortic stenosis, they will have post-stenotic dilatation of the aorta. Now let me just show you a clear X-ray which gives you an explanation of post-stenotic dilatation of the aorta. Now if you see this X-ray here, you can make out. So here is somewhere your aortic valve and this is your ascending aorta. So ascending aorta, if you see that there is post-stenotic dilatation of the aorta. So post-stenotic dilatation of the aorta is the classical X-ray picture in patients with the aortic stenosis. And it is not the dilatation of the aortic valve. Like in aortic stenosis, the aortic valve, it gets narrowed. And widening of the aortic knob, right? You see this is your aortic knob. Right? So this is your aortic knob. Now I'll just show you in which clinical condition you will have the widening of the aortic knob. The widening of the aortic knob you will see in patients with, you see this? This is the widening of the aortic knob. So you will have this in patients with the aortic aneurysm. Right? This is what you will see in patients with the aortic aneurysm. So that was the discussion of the first question. Now followed by that, you see the second question. Now the recall which was given to me was, sir, there was an image based question with the fluid thrill. That was the only recall. So then I have just acquired this particular image from the various sources, and this image may not be there in your exam, but the question was similar to like this. So what is the test? The shifting dullness, fluid thrill, checking the abdominal tenderness and as well as the palpation. So this is the options which are given to this particular question. So what is the test which is being done here is the fluid thrill. Now the shifting dullness, fluid thrill, these are all the tests which are being done for testing the ascites, right? For testing the ascites. Now, first of all, you take this shifting dullness. Shifting dullness, I'll just show you how is it done. First of all, you need to make the individual to lie in supine position. Then you start percussing from center to the peripheral area. If the individual has ascites, what will be the percussion note? The center will be the tympanic note, and in the flanks you will have the dull note. Then you ask the individual to lie in the right lateral position. You ask the individual to lie in the right lateral position. So in such case, what will happen? The fluid from the flanks will shift, that is from the left flank, it will shift to the right flank. Thereby what happens? So over the left flank you will have the tympanic note, and over the right flank you will have the dull note. So this is what is called as shifting dullness. So shifting dullness is being done, or it will be positive, when the fluid quantity in the peritoneal cavity is around 1000 ml. So then the fluid cavity in the peritoneal cavity, or when the fluid which is present in the peritoneal cavity is around 1000 ml, that is the point when the shifting dullness will be positive. Alright, next. Coming to the, you see this particular sign. This is what is your Poodle sign. Now, in which clinical scenario, you will do this Poodle sign. Poodle sign is also again the same thing, to make out the presence of the ascites. But the only thing is, the Poodle sign will be positive when the quantity of the fluid in the peritoneal cavity is around 200 ml. And this is your fluid thrill. The fluid thrill will be positive when the quantity of the fluid in the peritoneal cavity is around 2000 ml. Right, it is around 2000 ml. So these are all the various maneuvers which are being done in order to assess the presence of the ascitic fluid. Now, so in the fluid thrill, what will you do? One examiner will keep a hand in the center, and the other examiner will try to tap right hand, wherein the left hand will feel that particular thrill. Okay, so this is what is the fluid thrill, and the fluid thrill will be positive when the quantity of the fluid is more than 2000 ml. Right, so the answer to this particular question is the fluid thrill. Now, followed by that, you see the next question. This was the other recall which was given to me by the students. So they gave an image of Roth spots and Janeway lesions and asked what is the abdominal finding of this particular case. Right? They didn't give you the option, they didn't give you the images explanation. They just gave the images. They didn't give you, this is Roth spot, this is Janeway lesions. Nine. The recall what I got was, sir, they gave the images of Roth spots and Janeway lesions. See, this is your Janeway lesions, right? And this is your Roth spots. This is your Roth spots. So, presence of Janeway lesions and as well as Roth spots, what is this suggestive of? This is suggestive of infective endocarditis. Now, in infective endocarditis, what will be the abdominal finding? In case of infective endocarditis, the abdominal finding includes the presence of splenomegaly. Right? Abdominal finding includes the presence of splenomegaly. So that is what will be the abdominal finding in patients with infective endocarditis. And infective endocarditis, the most common symptom will be fever. And most common clinical finding will be cardiac murmurs. So that is about the infective endocarditis. Then, followed by that, yes. So I was said that there was a question on how will be the flow volume loop in case of obstructive lung disease. Right, sir, they have given us the 4 options, and all the 4 options were images only. And out of those 4 images, they have asked us to pick up which of the following image is suggestive of your emphysema or obstructive lung disease. That was the recall which was asked. Now, directly I am just showing you the option with obstructive lung disease. Now, this is a flow volume loop. Of obstructive lung disease. Now in this flow volume loop, remember, this is your inspiration, right? Inspiratory component. Then this is your expiration. Right? This is your expiration. Now in obstructive lung diseases, what will happen? The expiratory component will be reduced. Right? Expiratory component will be reduced. So when expiratory component is reduced, what will happen? You see, in this flow volume loop of expiration, this is the normal expiration. Right? This is the normal expiratory flow volume loop. Right? In obstructive lung disease, what will happen to the expiration? The expiration will be reduced. Okay, the expiration part of the wave of your flow volume loop will be compressed. So that is what you will see in patients with the obstructive lung disease or emphysema. Right? Now, after this, you take the next question. Right. So this was the other question which was asked. A person comes with a chief complaint of pain on the face when smiling, and when he touches the face also, the pain was getting accelerated. What is the medication you will prescribe? Right? They didn't give you, right? They didn't give you the diagnosis. Diagnosis was not given, but this was the recall by the student. Sir, like the clinical scenario was similar to that of your trigeminal neuralgia. Now, what is the drug of choice? The options are morphine, Ascites, levetiracetam, and as well as carbamazepine. So let me tell you that the drug of choice in patients with the trigeminal neuralgia is carbamazepine. Right? Drug of choice for trigeminal neuralgia is carbamazepine. And if the individual is refractory to carbamazepine, what you can give is oxcarbamazepine. Right? If the individual is refractory to carbamazepine, then you need to give oxcarbamazepine. And if the individual does not respond to your oxcarbamazepine, the next thing like what you can do is you can give baclofen. Baclofen is the other drug. And apart from the baclofen, the other drug like what we have is the lamotrigine. Right? The other drug what we have is lamotrigine. Okay. Now, if the individual is refractory to medical management, if the individual is refractory to medical management, so if the individual is refractory to medical management, remember this, you have to do rhizotomy. Right? You have to do rhizotomy. So wherein you need to ablate the root of the trigeminal nerve. Okay. So that is about the treatment of trigeminal neuralgia. Then you take the next question. Yes. So this was the other recall by the students. An elderly patient with hypertension fell down. His blood pressure was 200 by 110 millimeters of mercury. And sir, a CT scan image was there that was suggestive of bleed. That was the recall by the students. The options are start antiplatelet drugs. Platelets are transfused even if the platelet count wasn't low. Reduce the blood pressure to less than 120. Putamen is the most common site of hemorrhage. So these are the options. Now let me tell you, when the blood pressure is around 220 by 110 millimeters of mercury and then the individual fell down, you should think of hypertensive hemorrhage. Right? You should think of hypertensive hemorrhage. And what is the most common site of hypertensive hemorrhage? That is the putamen. So putamen is the most common site of the hemorrhagic stroke. And in patients with a hemorrhagic stroke, you have to reduce the blood pressure only up to 140 millimeters of mercury. Right? You have to reduce the blood pressure only up to 140 millimeters of mercury. You should not reduce it to 120 millimeters of mercury. No, you have to reduce only up to 140. And in individuals who had a hemorrhagic stroke, start antiplatelet drugs is a completely an incorrect statement. You need to start the antiplatelet drugs in ischemic stroke, but not with the hemorrhagic stroke. Alright. So this is about the putamen is the most common site of hemorrhage. I'll just show you a CT of that. So this is the CT scan suggestive of the Pontine hemorrhage. Right. So this is your Pontine hemorrhage. So the hemorrhage, it appears as a hyperdense lesion within the CT scan. So this is suggestive of your Pontine hemorrhage. Okay, next. Yes, so this was the other recall which was given to me by the students. The question, sir, they have given images and they have asked what is the diagnosis. And images, what all they have given is, they have given ascites, they have given the Dupuytren's contracture, and they have given the image of ascites. And they have asked what is the diagnosis. The options were congestive heart failure, alcoholic liver disease, and as well as the cirrhosis of liver. Now this is one of the very important questions where many of the students have done the mistake, right? So they have gone for the alcoholic liver disease. But remember, it is not the alcoholic liver disease which is the answer, it is the cirrhosis of liver which is the answer. Now why? Why not alcoholic liver disease? Let me tell you that the patients with the alcoholic liver disease, they can present with steatosis, right? That is fatty liver. They can present with fatty liver, they can present with hepatitis, and they can present with cirrhosis of liver also. Now, once they are presenting with fatty liver or hepatitis, let me tell you that they will not have these manifestations. They'll have this ascites, they'll have this Dupuytren's contracture, they'll have this icteric sclera in a scenario of cirrhosis of liver. So, if a patient with alcoholic liver disease, if he has gone into a stage of cirrhosis of liver, then they'll have these manifestations. In fatty liver and as well as alcoholic hepatitis, you don't see these manifestations, right? You will not see these manifestations, okay? So, the answer to this particular question is the cirrhosis of the liver. Right. So, if you see the next question, a patient suffered from vomiting, diarrhea for past 24 months. His urinary frequency was reduced. What will you find in this patient? The options are urinary sodium more than 40, kidney biopsy revealing the kidney damage, hyperosmolar urine, and post-renal obstruction. So, if you see the analysis of this particular question, the individual had vomiting, the individual had diarrhea. So thereby, what will happen to the fluid volume in the individual? The fluid volume is reduced. So when the fluid volume is reduced, what will happen to renal perfusion? Renal perfusion will be reduced. So once the renal perfusion is reduced, the individual will end up in what is called pre-renal type of acute renal failure. Right? The individual develops what is called pre-renal type of acute renal failure. Now, in pre-renal type of acute renal failure, what will happen to the urine concentration? They will have what is called hyperosmolar urine. The urinary concentration is increased. And you take the first option, urine sodium less than 40. Sorry, more than 40. In case of pre-renal type of acute renal failure, urinary sodium will be less than 10. So please remember that. In pre-renal type of acute renal failure, the urinary sodium will be less than 10. Whereas, in case of intrinsic renal failure, the urinary sodium will be more than 20 milliequivalents per liter. Okay, so this is a very, very important point. Then you take the second option. So your first option is ruled out now. You take the second option. Kidney biopsy revealing the kidney damage is not correct. Why? Because the individual is presenting with the manifestations within 24 hours. So it's a very short presentation. You cannot appreciate the kidney damage in the biopsy within this particular short presentation. Okay. Then post-renal obstruction. Post-renal, I think the option which was given was post-renal azotemia. So this was the later corrected to me by the students. Post-renal azotemia. So post-renal azotemia, you will see when there is presence of ureteric calculi, when there is presence of bladder calculi, or in males it could be because of your BPH, benign prostatic hyperplasia. Okay, so this is about the post-renal azotemia. So your post-renal azotemia is also ruled out. The answer to this particular question is the hyperosmolar urine. And if you see one more question that is very, very important, how will you differentiate pre-renal from intrinsic renal? This is very important point. Pre-renal fraction excretion of sodium will be less than 1. Intrinsic renal, the fraction excretion of sodium will be more than 1. So the answer to this particular question is the hyperosmolar urine. Alright, next. Now, so this was the other recall. They have just said me, the students have just said me, sir, there was an X-ray suggestive of hydropneumothorax, and they have asked us what will be the answer to this particular chest X-ray. So what is the diagnosis of this chest X-ray? The options are pleural effusion, pneumothorax, then hydropneumothorax. The answer to this particular question is the hydropneumothorax, and they were unable to recall what was the other option. And in hydropneumothorax, what is that you will have is, you will have the presence of, right, you will have the presence of straight line, right, and this straight line is mainly due to the fluid and as well as air interface. The fluid and air interface, where that is in the pleura, right, that is in the pleura. So you can make out here, see, this is the fluid, right, and this is the air, right, this is the air. So this is what is called as the straight line what you get in patients with the hydropneumothorax. Next, then followed by that, you take the chest X-ray in patients with a pleural effusion. So in pleural effusion, you can make out that this is the chest X-ray of pleural effusion. You can make out that there is presence of homogeneous opacity, right, in the lower part of the lung, and there is also blunting of the costophrenic angle. Right, there will be also blunting of the costophrenic angle. So blunting of the costophrenic angle is the earliest marker in chest X-ray. And the other thing is, they will also have the presence of a curve. And this particular curve is called as Ellis S-shaped curve. Right, Ellis S-shaped curve. So this is what is the chest X-ray picture in patients with a pleural effusion. So the answer to this particular question is the hydropneumothorax. So if you see the next question, so this was the other recall which I have got. The image may not be the same. They have asked the question, a image showing the description like the patient has the flexion of the proximal interphalangeal joint and extension of distal interphalangeal joint. Which condition is associated with it? The options are osteoarthritis, rheumatoid arthritis, psoriatic arthritis, and as well as the Reiter syndrome. So the question, if you see here, the abnormality is in the proximal interphalangeal joint. That is, there is flexion of proximal interphalangeal joint and there is extension of the distal interphalangeal joint. So now what does this show? This show a deformity which is known as buttonhole deformity or Bottonier's deformity. Right, buttonhole or the Bottonier's deformity. Now, there has been given two hands. That means there is symmetrical involvement in this particular disease. And I have asked to the students very particularly, did they give any changes in the nails? Right? So I did not get a proper recall, sir. We couldn't observe the nails properly. Why I have asked about the nails is, if there are changes within the nails, then I will suspect the psoriatic arthritis, right? If the changes in the nails are not there, and if there is symmetrical involvement of both the hands, suggestive of buttonhole or Bottonier's deformity, then the answer will be rheumatoid arthritis. And you take the first option, osteoarthritis. It need not be symmetrical. It can be asymmetrical also. That is about your osteoarthritis. And you take the Reiter's. Reiter's is characterized by a triad. Reiter syndrome, which is also called reactive arthritis, where you will have urethritis, arthritis, and as well as conjunctivitis. So that is what is your Reiter syndrome or reactive arthritis. Alright. Next. Followed by that, you see the next question. So the answer to this particular question is what? Rheumatoid arthritis. Now, if you see the next question, a patient came with the inflammation of metatarsophalangeal joint. The doctor prescribed a drug which lowers the serum uric acid. What is the mechanism of the drug? The options are xanthine oxidase inhibitors. Second option, thymidylate synthetase. Third option, ribonucleotide reductase. And fourth option, pyruvate carboxylase. So these are the options which are given to you. So what is the the clinical manifestation? Inflammation of the metatarsophalangeal joint. And you have prescribed a drug and that particular drug is lowering the serum uric acid. What is the mechanism of this particular drug? So what are the group of drugs which will lower the uric acid? That includes allopurinol, and the other important drug is febuxostat. So these are the drugs. The other drug is febuxostat. So these are the drugs which will lower the serum uric acid. Now if you take the mechanism of action of both these drugs, either you take allopurinol or the febuxostat, both of these drugs are xanthine oxidase inhibitors, right? Both of these drugs are xanthine oxidase inhibitors. The xanthine oxidase inhibitors, they will reduce the uric acid synthesis, right? Let me show you that. Now this is the flowchart of how the uric acid is produced. Uric acid, it is being produced from hypoxanthine. Hypoxanthine is converted into xanthine, xanthine is converted into uric acid. And what is the enzyme here? The enzyme is xanthine oxidase. And when you give allopurinol, allopurinol will inhibit this particular xanthine oxidase enzyme, and thereby the uric acid synthesis will not occur. Okay, so this is nothing but the mechanism of action of allopurinol or febuxostat, which decreases the serum uric acid synthesis. Now you see the next question. Right, so this is another very interesting question. The question given is patient with chest pain and diagnosed as the angina pectoris. His blood pressure is 150/90. Which antihypertensive drug is the first choice? The options are amlodipine, thiazide, atenolol, AC inhibitors. Now you see a very important clinical scenario. Okay, the patient's blood pressure is 150/90. Right? That means the blood pressure is increased. And along with that, the patient is having angina pectoris. Right, along with that, the patient is having angina pectoris. Now, in a combination of hypertension with angina pectoris, the ideal drugs that need to be given is cardioselective beta blockers. Either you can give atenolol or you can give metoprolol. So the answer to this particular question is atenolol. Right, the answer to this particular question is atenolol. All right. Now, then followed by that, and where is the reference? The reference is directly from the table of the Harrison. This is the table which has been directly taken from the Harrison. Now you take these beta blockers, that is cardioselective beta blockers. We have atenolol and as well as metoprolol, right? And these are the drugs which are used in the treatment of hypertension if the individual has angina. Actually, for hypertension, we have a big list of drugs. We can use thiazide diuretics, we can use the beta blockers, we can use alpha antagonists, sympatholytic agents, ACE inhibitors, ARBs and all. But cardioselective beta blockers has to be given as an antihypertensive if the individual has a parallel history of the angina pectoris. So that is the reason why the answer to this particular question is the atenolol. It is not the amlodipine, thiazide or the ACE inhibitors. Now, let me just show you the other question. Right, so this was the other clinical based question which was being asked, and the recall was not complete because the question was very lengthy. So a patient came in due to heart pain and his neck veins are engorged and blood pressure was less and heart sounds muffled, right? This is a questionable recall. Heart sounds being muffled. Some students said that, like, sir, they have given heart sounds were muffled. Some students said, no sir, this sentence was not given. And X-ray image was attached. What is the diagnosis, right? And the X-ray image was suggestive more of the cardiac tamponade. That was the recall which was given by the students. Now, what is the diagnosis? The options given to you are the pneumothorax, cardiac tamponade, and as well as constrictive pericarditis. The answer to this particular question is cardiac tamponade. The answer to this particular question is cardiac tamponade. Right, and if you in cardiac tamponade you have a triad, and what is that particular triad called? Beck's triad. Right, that is called as Beck's triad. Now, what does the Beck's triad show? The Beck's triad contain hypotension, right, raised JVP, and presence of muffled heart sounds. Right, presence of muffled heart sounds. So this is what is your Beck's triad, right, which is there in your patient. So BP is less, the heart sounds being muffled, neck veins being engorged. And the entire history was suggestive of the cardiac tamponade that was the recall by the students. So the answer is the cardiac tamponade. And in cardiac tamponade, like if you take the x-ray, so this is how the x-ray of a patient with a cardiac tamponade looks, right? So they'll have this cardiomegaly and they'll have what is called cardiac silhouette. And you will have this in the form of a narrow pedicle. Okay, so that was the question where the answer was cardiac tamponade. Alright, next. You see the next question. This is another very interesting question. Like they have tried to correlate the biochemistry with the general medicine. The question is, a woman came with a history of fatigue, on blood examination, macrocytic hypochromic anemia. On further examination, she has increased homocysteine in normal MMCoA, that is methylmalonyl coenzyme A. What is the diagnosis? The options are folic acid and vitamin B12 deficiency, folic acid deficiency, B6 deficiency. Now, if you see this macrocytic hypochromic anemia is seen in individuals where there is vitamin B12 deficiency and as well as folic acid deficiency. Right? So, in both these clinical scenarios, you will have that macrocytic hypochromic type of anemia. And you have one option, folic acid and B12 deficiency also. The other option, you have only folic acid deficiency. And the other option, B6 deficiency. The other thing is the individual is having increase in the homocysteine. Right? The individual is having increase in the homocysteine. That is hyperhomocystinemia. Now, what is the answer to this question? Let me show you. So, first of all, you need to see this flowchart of the metabolism of the homocysteine. See, homocysteine, it is being converted into methionine in the presence of vitamin B12 and as well as the folate. If there is vitamin B12 or folate deficiency, then homocysteine is not converted into methionine. There will be hyperhomocystinemia. And the other important thing is, this homocysteine is also converted into cystathionin in the presence of vitamin B6. Right? The homocysteine is also converted into cystathionin in the presence of the vitamin B6. Alright. Now, what you should understand is, if this vitamin B6 is not there, then homocysteine is not converted into cystathionin. Right? Homocysteine is not converted into cystathionin. And thereby, that will also lead to what is called hyperhomocystinemia. Right? Thereby, that will also lead to what is called hyperhomocystinemia. So, hyperhomocystinemia can be there due to vitamin B6 deficiency, due to B12 deficiency, due to folate deficiency. But among these three, which deficiencies will cause macrocytic anemia? It is only B12 and folate deficiency. It is only B12 and folate deficiency which will cause macrocytic anemia. Now, how will you make out? Right? How will you make out whether it is B12, whether it is folate, or whether it is both? See, there is normal levels of methylmalonyl coenzyme A. Now, let me just tell you about the metabolism of this methylmalonyl coenzyme A and correlating that with the vitamin B12. See, vitamin B12, it converts methylmalonyl coenzyme A to succinyl coenzyme A. Right? It converts methylmalonyl coenzyme A to the succinyl coenzyme A. That will happen if the vitamin B12 is present. If vitamin B12 is not there, then there will be increase in your methylmalonyl coenzyme A levels. But what is given to us in our question? In our question, it says that the methylmalonyl coenzyme A levels are normal. So what does that tells you? That tells you that the vitamin B12 levels are normal. The answer to this particular question is only folic acid deficiency. It is not both folic acid and B12 deficiency. It is only a folic acid deficiency, right? So this is about the clinical correlate between the general medicine and as well as the biochemistry. Now, yes, this is another very interesting question and where many of the students have done the mistake on this question. An elderly patient has developed rigidity, bradykinesia, and the student said, many of the features were suggestive of Parkinsonism. Okay. Which drug you will not give to the patient? The options are rivastigmine, propranolol, carbidopa, anticholinergic drug. These were the options. Now, you take this rivastigmine. Rivastigmine is what? It is a parasympathomimetic drug. right? It is a parasympathomimetic drug. Now, the parasympathomimetic drug, rivastigmine, it is used in the treatment of Alzheimer's dementia. Right? It is used in the treatment of Alzheimer's dementia. And it is also used in the treatment of Parkinson's dementia as well. Right? It is also used in the treatment of Parkinson's dementia as well. But if you see the question, there is no history of dementia. So that is the reason why rivastigmine will not be given in this patient. It is not required. Whereas you take all the other drugs, ropinirole, carbidopa, anticholinergic drugs, all those are given in the treatment of your Parkinsonism with rigidity, bradykinesia, and as well as tremors. Okay. So the answer to this question is rivastigmine. Rivastigmine is the treatment given in Alzheimer's dementia. Next, Parkinson's dementia. But here the patient does not have any feature suggestive of dementia. Next. Yes. So this is another very interesting question. A child with urine of output less than 0.4 ml per kg per hour for past 6 to 12 hours. What is the KDIGO staging of the patient? Okay, so KDIGO staging stands for kidney disease outcome. Now, according to that, what does the stage belongs to of this particular child? 1, 2, 3, 4. The answer to this question is stage 1. Now, let me just show you the KDIGO staging for acute kidney injury or acute renal failure. So, if you take the KDIGO definition of the acute kidney injury, we have stage 1, 2 and as well as 3. Stage 1, you have the urine output less than 0.5 ml per kg per hour for nearly 6 to 12 hours. Stage 2, you have the urine output less than 0.5 ml per kg per hour for more than 12 hours. And stage 3, the urine output is less than 0.3 ml per kg per hour for more than 24 hours. That is what is your stage 3. And what is given to us? Less than 0.4 ml per kg per hour for 6 to 12 hours. Then what will be the staging of this particular patient? The staging of this particular patient will be stage 1. Okay, so the answer is A. Now, followed by that, you see the next question. Yes, so this is also another important recall. The image may not be the same, but this was probable image or similar image to that what has been given in your exam. So the question is, a male tourist developed cyanosis of the toes after an expedition in the Himalayas. Image was also attached. Which of the following will not be given to him? Aspirin, oxygen, pentoxifillin, warfarin. So what is this patient suffering with? Okay, first of all, what is this image suggestive of? Suggestive of peripheral cyanosis. Right, this image is suggestive of peripheral cyanosis. And this peripheral cyanosis is very common in patients with the peripheral vascular disease. And these patients with the peripheral vascular disease, in order to prevent the development of the peripheral cyanosis, you need to give oxygen supplementation. Antiplatelet agents like aspirin is also given. Then we can also give pentoxifillin. Right? We can also give pentoxifillin. Okay. And the one which is not required to be given in patients with peripheral vascular disease is your warfarin. Right? So warfarin is not required here. So which of the following will not be given to him? Warfarin cannot be given or need not be given in this patient. Next. You see the next question. Yes. So this was the other recall, but the recall of all the CNS symptoms was not there in the question. An alcoholic developed gait abnormalities, paresthesia, and many of the other CNS symptoms. So, like symptoms were of 2 lines. That was the recall by the students. And can you recall? No, sir. I can recall only these many manifestations. Okay. Which vitamin is deficient in the individual? Now, if you see, the individual is alcoholic, right? So, in alcoholics, mainly we come across vitamin B1 deficiency, that is thiamine deficiency, and there will be also B12 deficiency. Right? There will be also B12 deficiency. Right? These 2 deficiencies can be there in an alcoholic. Right? So, if you give me the symptoms, like whatever the symptomatology which has been recalled to me is suggestive of both. Gait abnormality will be there in B1 and B12 deficiency. Paresthesias also will be there in B1 and as well as B12 deficiency. So how can I come to a conclusion of this particular question? It is only when, if I know the other manifestations in this question, then I can come to a conclusion whether it is B1 deficiency or it is B12 deficiency. Right? See, why B12 deficiency? Why? Because of impaired nutrition or reduced nutrition intake by an alcoholic, that can cause this B12 deficiency. Right? So it is, the answers are both B1 and B12. So depending upon what are the additional clinical manifestations, we can corner the answer to either B1 or B12. Alright, next. Now you take B12 deficiency symptoms. If you take the B12 deficiency symptoms, that includes headache, dizziness, muscle fatigue, rapid heartbeat, balance problem. Balance problem is nothing but gait abnormality. And they will also have finger or hand numbness and as well as tingling. The paresthesias will be there within the hands. Alright. Next. Now you take the B1 deficiency. B1 deficiency in adults, if you see, you can have ataxia and you can also have the tingling and numbness in the limbs. So I got only the recall of these two, that is ataxia is there and tingling and numbness is there. So that will be there in both B1 and as well as B12 deficiency. Alright, next. Now, if you see the next question, prophylactic irradiation of the brain is done in which cancer? Small cell carcinoma of the lung, seminoma, Hodgkin's lymphoma, prostate cancer. Let me tell you, the small cell cancer of the lung, which is also called oat cell carcinoma, this is the one which will metastasize to the brain. Right, this is the one which will metastasize to the brain. So in order to prevent the metastasis, you need to give a prophylactic irradiation of the brain. Right, you need to give prophylactic irradiation of the brain. So the answer is small cell cancer of the lung or oat cell carcinoma. Next, you see the next question. So the other recall which was said to me was, sir, there were few symptoms of a 30-year-old female and there was also a chest x-ray showing bilateral hilar lymphadenopathy. So more or less, right, they said like the image is not the same, sir, but it was more or less looking like that. So you are having the presence of bilateral hilar lymphadenopathy, right, and that too in a female. So what would be the answer? The answer would be sarcoidosis. The answer would be sarcoidosis. Okay, right. Now if you see the next question, vitamin D resistant rickets is due to defective calcium absorption in the kidney, defective phosphate absorption in the kidney, defective calcium and phosphate absorption, defective calcium absorption from the GIT. So your vitamin D resistant rickets, it is nothing but defective calcium absorption from the gastrointestinal tract. So there is impaired calcium absorption from the GIT. That is what does the vitamin D does? Vitamin D, it will cause the absorption of calcium from the intestine. That is what is being done by your vitamin D. And in case of vitamin D resistant rickets, there is defective calcium absorption from the gastrointestinal tract. That is what is called as the vitamin D resistant rickets. Then followed by that, you see the next question. An HIV patient with CD4 count of 350, right, CD4 count of 350, developed cough and features of tuberculosis. What will you do for the diagnosis? The options are CBNAT, liquid chromatography, and smear for microscopy. Okay, so smear microscopy, and the CD4 count is 350. Right, now you are suspecting tuberculosis. And investigation of choice for tuberculosis is CBNAT. What does the CBNAT stands for? This CBNAT is nothing but cartridge based nucleic acid amplification test. That is what is called as the CBNAT. So the answer to this particular question is the CBNAT. We have multiple investigations for tuberculosis, but the investigation of choice is your CBNAT. Alright, next. Yes. In recurrent UTI, which drug is less effective? Ceftriaxone, levofloxacin, moxifloxacin, ofloxacin. See, in UTI, definitely we give quinolones. And we also give the third generation cephalosporin. Ceftriaxone is also given. Levofloxacin is also given. Ofloxacin is also given. But the point is, you take this moxifloxacin. Moxifloxacin is a quinolone which is given in the treatment of respiratory tract infections. Right, in the treatment of respiratory tract infections. So the answer to this particular question is moxifloxacin. So in recurrent UTI, which drug is least effective? It is your moxifloxacin which is least effective. Right, so the answer is 3. Yes, this is another important question. This was a recall like where the serology was not being recalled properly. Right, I still have a little confusion regarding this particular question, but let me just try to summarize. So he gave a serology of hepatitis B where anti-HBC IgG is positive, surface antigen is positive, that too anti-HBS, and envelope antigen is negative. Like, what is the diagnosis? Acute, chronic, recovered, immunized. So if you consider that IgG is positive and anti-HBS is positive, if anti-HBS is positive, that tells that the individual is cured. That tells that the individual is immunized. That tells that the individual is having no active disease. Envelope antigen is negative. That means infectivity is less. Right? Infectivity is less. And IgG is positive. That tells that it is chronic hepatitis B. That tells that it is chronic hepatitis B. Alright. So, the answer in this question will be chronic hepatitis B. Now, the point is, anti-HBS is positive. We have a clinical entity called, I'll just show you a table here. Yes, you see this. IgG anti-HBC is positive. Anti-HBS is also positive. And envelope antigen, it is either positive or negative. So it is chronic hepatitis B with heterotypic anti-HBS. Right? It's a chronic hepatitis B with heterotypic anti-HBS. So the answer to this particular question is chronic hepatitis B. Then what will be the serology in case of immunized? In case of the serology, whoever are immunized, now you see, in case of serology of immunized, only anti-HBS will be positive. You see this. Only anti-HBS will be positive. IgG anti-HBC will not be positive in immunized individual. Only anti-HBS AG will be positive. Okay. So that is your anti-HBS. Next, you take acute. Acute means the individual should have IgM anti-HBC. So your IgM anti-HBC is not there. So that is the reason why your acute hepatitis B is ruled out. Now you take the other options. The next. Yeah. So these are some of the questions what I could get from the recall of your FMGE paper. And definitely I tell that the paper is not so easy. The paper was very difficult. Right? So even in the upcoming December exam, we will always hope for the best. Right? We will always hope for some easier paper than this. But at the same time, we should also be prepared for a tough paper like this. Right? We will hope for the best. Definitely we pray for an easier paper. But everything will not just go according to our prayers what we do. So we will hope for the best and we will be also prepared with the worst. So with this, I conclude the discussion. Thank you very much.